On respiratory disease, I will discuss first the anatomy of the lung. And the anatomy of the lung includes the bones, the vertebra, the ribs, the sternum, the lower airways, the trachea, bronchial tree, bronchioles, and alveoli, the blood supply to the lungs, the pulmonary arteries, veins, and the bronchial circulation, as well as lymphatic drainage, the muscles that move the lung, the thoracic cage muscles, the intercostals, the diaphragm, the lining of the lung and the internal aspect of the thoracic cage, the visceral and parietal pleura, and we'll also touch on some of the nerves involved, the phrenic and the vagus nerve. One aspect I won't discuss, but is very important, is that the respiratory tract actually starts at the nose. So the upper airways are part of the respiratory tract as well, and that includes the nose, the mouth, the sinuses, the pharynx, the larynx, and the vocal cords. Right, so this diagram gives a general overview of the respiratory tract. And you can see in the middle the grey objects are the lungs, the right lung on the right-hand side, the left lung on the left-hand side, and then nestling either side of the heart and the pericardium. And on the outside, we have a layer of skin, muscle, and then we have bones. And you can see the pleura, which actually hangs down below both lungs on both sides. And underneath the thoracic cavity, we have the right and the left hemidiaphragms, which separate the thoracic cavity from the abdomen and are vital for respiration. Above the thoracic cavity, we have the trachea, which takes air in and out of the lungs and up into the upper airways in the neck. This is a more schematic diagram showing the airways in entirety, starting at the nose, moving on to the pharynx, which is at the back of the nose, and then the larynx, the trachea, the bronchi, and then the lungs at the end of the respiratory tract. The other aspect of management is this correction of oxygenation. If you have consolidation, you are replacing air in the alveoli with inflammatory fluid. And that causes hypoxia because it generates what we call a right to left shunt. And what I mean by that is that blood coming up the pulmonary artery, which is deoxygenated, will reach the area with the consolidation in it, will go through that area, but because there's no air in the alveoli, that blood will not be oxygenated, and therefore it will reach the pulmonary veins in a deoxygenated state. And you end up mixing the deoxygenated blood coming from the consolidated lung with the oxygenated blood coming from the remaining normal lung. And the consequence of that is that you add mixture of hypoxic blood and normoxic blood, and the combination of the two will dictate how hypoxic the patient will be. So in this example, for example, we have a patient who has quite extensive consolidation, and therefore the deoxygenated blood shunting through that consolidated lung has a significant effect on the arterial oxygen concentration, reducing it down to about 80%. So oxygen needs to be corrected, and we do that using masks and, if necessary, mechanical ventilation. Another important physiological upset that occurs in patients with pneumonia is due to the sepsis, due to the septic shock potentially that can develop in a minority of patients with acute bacterial pneumonia. Before that, actually many patients, because they've been breathing fast, unable to drink and eat, they're dehydrated. So dehydration is common, and beyond that, some patients will develop septic shock with persisting hypotension even after they've been rehydrated. And acute kidney injury is very common in these patients as a consequence of these problems. So patients with pneumonia will require intravenous fluids to rehydrate them if they have got a low blood pressure or clinically they're dehydrated. And if the low blood pressure persists despite rehydration, then you need to consider inotropes and admission to intensive care to treat for septic shock and to avoid the downstream consequences of having hypotension, increasing kidney injury, etc., etc. So we can characterize asthma into various different subtypes as well. Chronic asthma, this is when you've developed an element of irreversible disease leading to chronic dyspnea or a chronically low FEV1 and reflects poorly controlled disease over many years. An exacerbation, that's an acute deterioration stimulated often by the triggers we've just discussed. A severe asthma is an attack of asthma that's bad enough to require admission to hospital. So that's an exacerbation that requires somebody to come into hospital. Status asthmaticus is one level above that, where you have an exacerbation which is severe enough to be life-threatening. and requires very close attention to the treatment to ensure that the patient gets better. And there's not an instant response. It's not with a less severe exacerbation. One dose of nebulizer is probably normally enough to restore them to reasonable health. In status asthmaticus, it requires much more intense treatment than that. Doctors often use the phrase bronchospasm, and all they mean by that is an episode of increased bronchial obstruction, an increased episode of airways obstruction, and that essentially is an exacerbation. Other subtypes of asthma include brittle asthma, and these are patients who actually are relatively well most of the time, but then can have sudden exacerbations which can be very rapidly developing. I have a patient who went down into the kitchen one day feeling perfectly well, and next time she woke up, she was in hospital in intensive care. And what had happened is that somewhere in the kitchen, something had set off her asthma attack. And fortunately, the postman found her when he came to deliver a parcel that day. Otherwise, she would have been dead. That's brittle asthma. Very rapid attacks, rapid falls in peak flow, very severe, and because of that, very dangerous disease. Difficult asthma is a range of problems. It's when the asthma is poorly controlled and causing major symptoms for the patient or frequent admissions to hospital. And it's defined as difficult asthma when it's poorly controlled despite extensive treatment. And there are a variety of reasons why that might be not responding to the treatment. Steroid-resistant asthma is a subtype of difficult asthma, which is very specific. It's where steroids, which normally work very well in asthma, are not working. The type of inflammation that patient's asthma is due to does not respond to corticosteroid therapy for whatever reason. Cough variant asthma is essentially very mild asthma where the only symptom the patient has is cough. And this one's quite hard to diagnose because there's no wheeze and breathlessness, and patients don't think that the cough could be due to asthma, and nor do their doctors either. Occupational asthma we've already discussed. That's asthma that's set off by inhaled allergens that you come across during your occupation. It's very important to identify it because clearly the patient will need to change their job circumstances, either change their job or make sure that they have protective equipment when they're doing their job to try and minimize the disease problems. So, how do we make a diagnosis of asthma? Essentially, we need to prove there's reversible airways obstruction. Now, as I mentioned, clinically, that may be obvious in some patients, and therefore the requirement to prove that it's present is not so important. But it can be proved in other ways. One is by response to treatment. Somebody comes to you with episodes of cough and breathlessness and wheeze, and it sounds very much like they have asthma. Perhaps it's diurnal variation, it's worse in the morning, the cough wakes them at night. Every time they get a cold, it's made worse. Those sort of patients, you probably don't actually need to do too much besides give them the right treatment, and if they get better, then that's asthma. If you really want to prove it's asthma, peak flow recordings are a good way of doing that. Now, these record the air flow during expiration, and they show diurnal variation in asthmatics. So, for example, in this chart you see on the right-hand side of the slide, there's a big fall in the peak flow in the morning. Now, when you start an inhaled steroid, what happens is that the peak flow will gradually improve as the asthma comes under control, but not only that, is that the difference between the morning and evening, the diurnal variation, becomes smaller. So home peak flow recordings, with and without treatment, are a very good way of identifying patients who have asthma for sure. And you can also use spirometry, the FEV1. And I showed a spirograph earlier with FEV1, which improves substantially after a bronchodilator, showing significant reversible disease, and therefore the patient has asthma. Other tests, well, blood tests may show a degree of blood circulating eosinophilia, and the patient often has a raised total IgE and can be allergic to aspergillus, especially if they have allergic bronchopulmonary aspergillosis, which is a complication of asthma, which I'll discuss in a subsequent lecture. The chest X-ray is necessary to make sure you're not missing any other diseases, but essentially is normal in most patients with asthma, unless they have an acute attack or chronic severe disease, in which case that will show hyperexpanded lungs. But as I said, a chest X-ray is vital during exacerbations at least to make sure there's no other complications such as a lobar collapse or an infection. We often do skin prick tests in patients with asthma, and that's to identify specific allergic triggers for allergic asthma, house dust mites, cat fur, etc., etc. In many ways, it's not very practical because if a patient knows that a cat will upset his or her asthma, then they avoid cats. It's only particularly relevant, I suppose, for patients where you might be considering allergic bronchopneumonia as a diagnosis, in which case the skin prick test will be positive for Aspergillus. Occasionally, you might come across a patient where it's quite hard to identify they have asthma, and then we might do things like a histamine or methacholine challenge test, where the patient inhales histamine or methacholine, and that causes bronchoconstriction in patients who have asthma, but it doesn't in patients who don't have asthma. So that's inducible airways obstruction. It's quite a tricky test, needs to be done in hospital in a fully equipped pulmonary function laboratory, but can be used to identify difficult cases of asthma to diagnose. And the sputum itself may show evidence of airways inflammation with the presence of eosinophilia when you send the sputum off for cytology.
Now, the asthma treatment therapy will go from what's known as relatively mild to severe. First and foremost, you always take history. And with the history, you're looking for what's the most common type of asthma? Extrinsic, go step by step, exposure to the external world, and that's called atopy, right? Atopy. So maybe your patient needs to then remove himself or herself from that environment. That's your first step of management, if that's the case. Next, short-acting bronchodilator. So what does that do? Oh, albuterol as needed, puff, 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 whenever they're having an attack or bronchospasm, and so therefore relieves that obstruction. Next, what about inhaled steroids, ICS, corticosteroids, low to mid? Remember, inhaled corticosteroids is going to do what? It's going to then help you with some of that bronchoconstriction, perhaps. And whenever you deal with your corticosteroids, you tell me, what enzyme is it knocking out? Is it LOX? Is it COX? Or is it phospholipase A2? Good. It's phospholipase A2. You've knocked out the leukotriene and prostaglandin pathway, haven't you? And by knocking out some of that leukotriene pathway, especially CDE4, then you may then avoid bronchoconstriction. Are you clear about that pharmacology? Management's important.
The 2020 GINA guidelines recommend inhaled corticosteroids as the preferred reliever for patients who present with symptoms less than twice a month and for the prevention of exacerbations. Short-acting beta-2 agonists can be used in addition if needed.
Continue. Long-acting beta agonist, leukotriene modifier. Give me some. Well, what if you knock out the LOX, xylulin? What if you knock out the receptors for leukotrienes, Cas, montelukast, zafirlukast, things you've looked at? Is that clear? Which leukotrienes are you trying to avoid in asthma and bronchospasms? CDE4. About theophylline. Theophylline will help you, well, this goes back to biochemistry. You should be liking this. This beta-2, that's a receptor on the bronchi and smooth muscle. What does it work through? What second messenger from biochemistry? Good, GS. What does GS mean to you? A. What do I mean, A? Well, that's your adenocyclase. That's your ATP to cyclic AMP. Oh, that means protein kinase A. Oh, what does that mean? I am knocking out my myosin light chain kinase because I phosphorylated. Do you remember all this? If you don't, this would be a good time to go back and take a look at your biochemistry with smooth muscle mechanics. See, if you knock out the myosin light chain kinase, guess what happens to the bronchi? Relaxation. So what do you think theophylline might do? Theophylline, well, how does cyclic AMP break down? Phosphodiesterase. What if you inhibit some of that phosphodiesterase? Voila! You knock out the phosphodiesterase, you have cyclic AMP forevermore. Isn't that what you want with beta-2? Yes, you do. Now, I'll tell you right now, the two major approaches for smooth muscle relaxation, especially for the bronchi, either beta-2, you look for that mechanism in pharmacology and biochem, and you take a look at NO, okay, nitric oxide, please. Those are two that you want to pay attention to. Let's continue. We have anti-IgE therapy. All right, so with IgE therapy, you're thinking about, well, some of those drugs that inhibit what? Your breakdown of your mast cell. So anything that then inhibits the degranulation of your mast cell is always important. Hence, you're looking at things like this, anti-IgE therapy. All right, now in terms of severity, we're just going to move from top to bottom, which is just the severity in the beginning will be quite minimal. And then as you go through your severity and it gets worse, then obviously as far as management, things become a little bit more complicated. Prevention and all. So how do you educate your patient? Important. If you can avoid giving medication to your patient, that is your answer. So therefore, educate your patient. Oh, hey, doc, my child is having coughs episodically. Oh, okay. I can hear kind of wheezes and such, okay? And he goes and plays. He plays in this particular park, and every time he comes back after he plays, he doesn't seem so well. Okay, so you want to try to figure out as to, well, what was the child exposed to in that park that makes him feel like this? Prevention, prevention, prevention. And after this, mild intermittent, mild persistent, moderate persistent, and severe. Remember, we start getting to severe and such, and even at night, if there's coughs, not a good sign. So you need to make sure that you intervene ASAP. Let's talk about that acute flare. So during the acute flare in your head, you should be thinking about that loop spirometry, which we saw a scalped portion. Here, when you have an acute flare, what are you trying to do? Immediately try to bronchodilate, nebulizer. So what does that mean? That means that you have a gas mask, I call it as such, which is then attached to a machine, which is then exerting or expressing what? Albuterol. Ipratropium, keep in mind, there are two ways you can approach this, right? Either you could stimulate the beta 2 receptors. I just walked you through that in great detail. Or you could block your parasympathetic. Two methods. Albuterol, much more so. What else? Oral or IV steroids. IV steroids. What's my problem? Acute flare. Oxygen if hypoxia is present. Acute flare. Well, the magnesium, just keep that in mind. Magnesium is a big deal for you in medicine, though. Okay? Remember, with magnesium, two major things. Number one, seizures if it's hypomagnesemia. Also, if it's hypomagnesemia, you're thinking about long QT syndrome. So those are major things that you want to think about when dealing with magnesium. Close monitoring. Make sure chronic treatment are being used correctly. By chronic, we're talking about, is the patient on the right bronchodilator? Is it a beta-2 agonist? Is it a leukotriene inhibitor of the right type? Or maybe it's even a type of corticosteroids. So those are things that you want to keep in mind. Now, what I wish to bring to attention that you will be asked is if there is such an acute flare, especially when you have a child that has an asthma attack, not only is this child breathing really quick, and the diaphragm obviously is being used, but then the accessory muscles of breathing are also being used. Do you remember this conversation? So look for this, and don't forget, if you find a patient's come in and they're breathing, the sternocleidomastoid is working, and the intercostal muscles are working, this is a child who, at some point, those muscles are going to fatigue and tire. And the child starts quieting down, and maybe it's an intern who didn't know any better and feels as though that he or she has treated the child, and the child is quieting down, thinks that he or she is managing the child properly. But why is the child quieting down? The muscles are getting tired. The child's not breathing anymore. Wow. What's your next step in management? Intubate. Break a few teeth rather than have your child die on the table. Is that clear? That is a big deal. So what are you going to measure? You tell me. Use common sense. What are you going to measure in the blood? This will tell you that the child's acute flare is actually getting worse. The pH, of course. Because if the child's muscles are tiring and the child's not breathing, what is the child retaining? Carbon dioxide. Good. What happened to your pH? Decrease. Welcome to respiratory acidosis, and that is no joke.
What are the clinical signs of COPD? Well, with mild disease, in fact, there'd be very little to find when you examine the patient. But with more moderate, more severe disease, it may be evident that they have respiratory difficulty. They may be breathless, moving around the examination room. They may have an increased respiratory rate at rest. They may have to use their accessory muscles to breathe, and there might be excessive abdominal movement. And patients with more severe disease and exacerbations could show pursed lip breathing. When you look at the chest, it may be obviously hyperexpanded with a horizontal angle to the ribs and increased anterior-posterior diameter, the so-called barrel chest. And there may be tracheal tug with the cricothyroid cartilage coming down on inspiration towards the sternal notch. And when you examine the chest directly, the expansion will be reduced bilaterally on inspiration, and there'll be loss of the normal dull percussion note that you normally find over the liver and the heart. And the lungs might be expanded below the level of the 10th vertebra posteriorly. When you listen to the lungs, actually, wheeze, although it is a sign of COPD and airways disease, is not universally present. And in fact, is probably present in fewer patients than no wheeze. What they do have is a prolonged expiratory phase, and they have quiet breath sounds all over their chest. That's a very common sign. Patients with very severe disease may have the signs of complicating cor pulmonale, raised JVP, edema, etc. There's often a description of clinical phenotypes of COPD. As I mentioned earlier, there's an admixture of different pathologies that patients with COPD have, and that might dictate the clinical phenotype they present with. The two extremes of this phenotype is the blue bloater and the pink puffer. Now, they probably are not terribly useful clinical terms, but they are a useful way of illustrating the different type of pathology mixtures you may get in somebody with COPD. So, for example, a pink puffer, the emphysema component may be dominant in their pathology, and that's associated with a lot of muscle wasting, a cachexia, and a rapid respiratory rate using accessory muscles or pursed lips breathing, but no real cyanosis or angioedema because the patient is maintaining their respiratory function without tipping over into type 2 respiratory failure or significant hypoxia by compensating with a high respiratory rate. The blue bloater, on the other hand, airways obstruction is dominant, there's not much emphysema, and they seem to have chronic type 2 respiratory failure with hypercapnia and some cor pulmonale. And that means they're cyanosed, they have a relatively low respiratory rate, they tend to be overweight, and they have peripheral edema. But this is a spectrum, and patients frequently have a mixture of these features, and you can go from one to the other to a certain extent. So many patients with emphysema, although they're not hypoxic initially, eventually they will develop hypoxia and cor pulmonale and will present with cyanosis, angioedema, etc., etc. So how do we confirm the suspected diagnosis of COPD? Well, that's easy enough. We need to do some lung function tests. We need to record an FEV1 and an FVC. Both will be reduced if there's significant airways obstruction, but the FEV1 will be reduced proportionally further than the FVC because of the airflow obstruction, and that means the ratio of the two will fall. So, for example, in the spirometry shown here on this slide, the expected values for this patient will be 3.9 and 4.8, and that gives a ratio of FEV1 to FVC of the high 70s. However, the obtained values was 0.9 and 1.6. Those are both much lower than they should be, but also the ratio of FEV1 to FVC is closer to 50%, around 60% there. And the thing about the airways obstruction in COPD is that it's largely irreversible. There might be a small uplift with bronchodilators, but often there is no change at all in FEV1, and there's always a persisting level of airways obstruction. The peak flow records are not so useful in patients with COPD as they are of asthma, because the peak flow does not vary as much and therefore is not a useful way of analyzing whether the patient is having an exacerbation or is deteriorating in some way. A very important point, which follows from the slides that we discussed earlier, is that the FEV1 over time tells you how the patient is doing. And if the patient has an FEV1 less than 50%, that's probably severe COPD. The other aspect of lung function tests that you need to think about are the flow volume loops and the lung volumes. So the lung volumes are increased in COPD. The patient has bigger overall lung volumes than normal. That may seem surprising, but that relates to the air trapping that we discussed, that I mentioned earlier, and I'll discuss in more detail in a second. The reason for the increase in lung volume is that the residual volume, the amount of air left in the lung at the end of expiration, increases. And so although the lung volumes are larger, it's useless volume. It's not air that's shifting during inspiration and expiration. It's just the residual volume that's driving the increase in lung volume. If the patient has emphysema, then they've lost a lot of surface area for gas exchange because of the alveolar destruction. And that means the transfer factor, which measures the ability of oxygen to get in from the lungs into the blood, goes down. So a low transfer factor suggests emphysema. In addition, the alveolar structures are required for splinting open the airways as you breathe out. So on expiration, there tends to be there's a positive pressure in the thoracic cavity, and that squeezes air out of the lungs, but it also squeezes the bronchi, taking the air out of the lungs. And if the bronchi have lost their structural support, then there'll be a tendency for them to be closed off by that pressure, the expiratory pressure. And that's called dynamic airways collapse, and occurs in emphysema, where the loss and destruction of the alveoli mean the bronchi are not splintered open during that and cannot combat the positive pressure of expiration. And you can see that on a flow volume loop, which is illustrated here on the right-hand side of the slide. You can see that the person with emphysema, the solid blue line, what happens as they breathe out is there's a rapid increase in flow initially, and then there's a sudden decrease in flow due to this dynamic airways collapse. And that's followed by a prolonged phase of low flow expiration. The other investigations you need to do with somebody with COPD, well, clearly a chest x-ray is useful, but actually it's not that abnormal in most patients. In patients with significant disease, it will show a degree of hyperinflation with reduced lung markings, more visible anterior rib ends than normal, perhaps flattened diaphragms and a small heart. You can see bullae on a chest x-ray. So some people who have quite expanded lung cysts due to COPD, that's a bullous, that's visible on a chest x-ray. And also chest x-ray is important to identify complications, pneumonia, pneumothorax, and chronically to make sure they don't have cancer. The CT scan is used to identify patients who have emphysema, to look for bullae, and perhaps to look for coexistent bronchiectasis or other complications. So these are some examples of x-rays you might see. The x-ray on the left-hand side of the slide is somebody with a hyperexpanded lungs due to COPD, and basically you see black lungs, very long, thin lungs, and the heart is stretched as well. And that's a hyperexpanded pair of lungs with oligemic lung fields. The middle CT scan shows central lobular emphysema, and what you can see are black holes where there's been lung destruction, with the grey material around the outside being the normal lung. It's a sort of Swiss cheese lung. It's got holes in it. The last scan is somebody who also has some emphysema, but that's distributed in a different way. Instead of being central lobular in the middle of the lung lobules, it's actually around the septum, around the edges of the lung lobules, around the edges of the lung. What other investigations are useful in COPD? Well, actually not much. Lung function, chest x-ray, some patients need a CT scan. Blood tests, you may want to measure the alpha-1 antitrypsin level to see whether they have early onset emphysema, if they're relatively young patients, especially if they have basal emphysema on their CT scan. Normal blood tests for blood count, Usenes, liver function tests are all normal. Some patients you need to do an echocardiogram and ECG, and there's two reasons for that. One, the main differential diagnosis for somebody with COPD would be cardiac breathlessness, congestive cardiac failure. So you may need, or a valvular problem such as aortic stenosis, and you may need to exclude that as a cause of their breathlessness. And the other reason why you need to do echocardiograms and ECGs is those patients with chronic hypoxia may develop cor pulmonale, and you need an echocardiogram to measure the pulmonary hypertension that could be present in those circumstances. Invasive tests such as bronchoscopy or lung biopsy are not needed for patients with COPD. They're not needed for diagnosis at all. So, how do you recognize the patients with COPD? It's a combination of gradually worsening breathlessness on exertion over years or months, with a significant pack year history, 25 to 30 pack year history. Therefore, most patients will be aged over 50 or so, plus obstructive spirometry. The chest x-ray often looks normal. The main differential diagnosis is congestive cardiac failure, chronic PEs, that will be a shorter history, and they'll have an abnormal transfer factor, and importantly, the lung volumes and spirometry will be normal. Chronic asthma, there's no history of smoking, there's definitely a past history of asthma in most of those patients. And pulmonary fibrosis, and this is where crackles are important, because if you hear crackles, that's not due to COPD. And in addition, the lung function pattern you get with pulmonary fibrosis is different. It's a restrictive lung function with an increased FEV1 to FVC ratio, and usually a fall in transfer factor as well. So, moving on to discuss pneumonia. The hallmark, the defining situation with pneumonia is that you have infection of the alveoli, and that causes consolidation. So that is where the air that's in the alveoli has been replaced by an inflammatory exudate, bacteria, white blood cells, and red cells, replacing the air. And you can see that on the chest x-ray. So for example, this chest x-ray shows somebody with a right upper lobe pneumonia, and there's a white patch over the right hand of the lung, and that reflects the dense consolidation that's occurring in that area, and there's no air left in those alveoli. And this distribution of pneumonia is a lobar pneumonia. It's affecting one lobe only, and the rest of the lungs are clear. And that's the commonest presentation of an acute pneumonia. You can get pneumonia which is patchy throughout both lungs. So little patches throughout both lungs. And that's called bronchopneumonia, and this is an example of that. This is a much more serious disease in general, because that's a very extensive infection and is often a fatal event in patients with underlying severe disease such as a cancer or another disability such as dementia or a chronic neurological deficit of some description. A third pattern of pneumonia that we can see is an interstitial pneumonia. Now, you probably can't tell very easily on this chest x-ray that it's abnormal, but there is a widespread reticular nodular infiltrate in both lungs, but it's very subtle. And that represents, again, a diffuse pneumonia and is commonly associated with the atypical organisms that I mentioned earlier, Mycoplasma and Chlamydia. The overall importance here is that if you have pneumonia, there is some form of alveolar consolidation, usually lobar, but potentially interstitial or bronchopneumonia as well. And we can detect that clinically. So if you have somebody with pneumonia, the area of infected lung, the area of consolidation, will be dull to percussion, and when you listen to it, there will be crackles in that area and potentially bronchial breathing. And the chest x-ray, as we've seen, is obviously abnormal. It shows airspace shadowing with white patches in the affected area, and occasionally what we call air bronchograms. That's where the bronchus that's moving through the consolidated lung has been delineated by the alveolar consolidation either side of it, so it shows up as a black tube going through a consolidated area. So, pneumonia is classified into different types. And the first and the most important, and the subject of most of this talk today, is community-acquired pneumonia. And that is what it says in its name. It's a pneumonia that is acquired when you're living at home and not in hospital or anything else. So it's the normal standard pneumonia that you pick up in your everyday life. The other important forms of pneumonia are hospital-acquired, which, as it says, is a pneumonia that you develop when you're in hospital. So you're admitted to hospital for another reason, say you're having an operation, and then after the operation you develop a pneumonia. That would be a hospital-acquired pneumonia. A third form of pneumonia is ventilator-acquired. That's basically a subtype of hospital-acquired pneumonia, but it means that this is pneumonia in patients who are on the intensive care unit being ventilated, and they are susceptible to pneumonia because the ET tube, the endotracheal tube, bypasses quite a lot of the normal immune mechanisms for preventing infection. And the last category is immunocompromised host. These are patients who have a very severe defect of their immune system, and that allows a range of unusual organisms, bacteria, viruses, and fungi to cause the pneumonia. So the chance of having a pneumonia to an unusual organism is much higher in these patients. But we're talking about patients who have severe immunocompromised state. So those who've had chemotherapy for cancer, those with HIV infection with poor CD4 counts, those who had transplantation of their marrow or of a kidney or their lung, etc. So patients really with very severe immune defects. So who gets pneumonia? Well, there's an easy answer to that question, and that is absolutely everybody could get pneumonia. It's not uncommon in young people, but it is particularly common in two age groups, the very young, the under fives, and as I mentioned before, it's the commonest cause of death across the developing world in the under fives, and the elderly. And there's an almost exponential increase in the chance of developing pneumonia after the age of 65. So it ends up that the chance of developing pneumonia in somebody who's very old, over 85, is about 5% a year. The risk factors for pneumonia also, as well as age, include previous influenza or other viral infections because, as I mentioned in the influenza lecture, a viral infection of the respiratory tract affects the immune response to bacteria and allows bacterial infection to develop as a consequence of the viral infection. So secondary bacterial pneumonias after influenza are very common, and that's the major way by which death is caused during the pandemics or has been in the past. For example, the post-World War I pandemic, which killed 20 million people. Most people died of pneumococcal and staphylococcus pneumonia after having the influenza virus infection. Other people who are more susceptible to pneumonia are alcoholics or people with liver cirrhosis because that affects the ability of the immune system to fight bacteria. Smokers, that allows the bacteria to establish infection in the lungs more readily. Actually, having had one episode of pneumonia makes you 2 or 3 times more likely to have another episode. It marks you out as somebody susceptible to pneumonia. And then patients with chronic disease, chronic lung disease, COPD, for example, chronic neurological disease, dementia, previous stroke, etc., any renal impairment or cardiac failure. These are all reasons why these all increase the chance of getting community-acquired pneumonia. Now, if you have hospital-acquired pneumonia, you need to be in hospital. So if you're hospitalized for a reason, then you're at risk of hospital-acquired pneumonia. And if you're ventilated, then you're at risk of ventilator-acquired pneumonia. And the risk of that is about 1% per day that you are ventilated. And then, of course, the patients who have immunosuppressed for their treatment of their cancer or because they've had a lung transplantation, etc., those will be at risk of pneumonia of the immunosuppressed patient. What are the symptoms of pneumonia? Well, actually, they're very straightforward. You have the systemic symptoms that you get with infection, fever, feeling unwell. Occasionally you get the shakes, the rigors, and you're not eating, and you feel terrible, and you want to go to bed. Then there are the focal symptoms you get because it's a lung infection, and that will be cough, producing a purulent sputum sometimes. Sometimes you get blood in that as well. And the mixture of purulent sputum with blood becomes what we call rusty sputum, a sort of browny color sputum. You may get pleuritic chest pain if the pneumonia is causing overlying pleuritic inflammation. That's called pleurisy. And because the pneumonia consolidation is affecting the ability of gas exchange in your lung, then you might be breathless as well. When you look at the patient and examine them, again, you have the general examination findings of somebody with an acute infection, pyrexia, they don't look very well, they may have they should have a tachycardia, and they have an increased respiratory rate because of the problem with the consolidation. There are a few other issues. If they have significant hypoxia, then they'll have central cyanosis. And pneumonia is a relatively common cause of acute septic shock, so they might have hypertension as well. And occasionally, patients have atrial fibrillation because acute lung infections are one cause of temporary atrial fibrillation. So that's the general examination. When you listen to the lung, we've already mentioned the signs, which essentially is focal asymmetrical crackles, crepitations over the areas of consolidation. If it's really dense consolidation, it'll be dull to percussion, and there'll be bronchial breathing as well. And about 1/3 of patients with pneumonia will have a small effusion, and some of those will have a pleural rub. So if somebody presents with pleuritic chest pain because of the pneumonia, the pleurisy, it's quite likely that there'll be a pleural rub over the area where they feel the pain. Now, if you're trying to work out whether somebody has a pneumonia or an acute tracheobronchitis, and this is a very important distinguishing situation because tracheobronchitis is a relatively benign disease and will settle, whereas pneumonia does have the potential chance of becoming a very severe disease. Then there are a few of these signs which are important. So, for example, you will not get crackles if somebody has a tracheobronchitis. So the focal lung signs that you get in pneumonia are not present if somebody has a bronchitis. In the general examination, if you have an acute tracheobronchitis, it doesn't cause impairment of respiratory function to a significant degree unless you have an underlying lung disease. And so in the normal patient, there shouldn't be an increased respiratory rate. They should not get cyanosis. And it should never get severe enough to cause hypertension or a particularly high pulse rate. So what are the principles of management of somebody who's presenting with what seems to be a community-acquired pneumonia? Well, first of all, you need to confirm the diagnosis. Then you need to assess the severity, and then you need to think about treatment. And that has 3 main components to it: correct the oxygenation, because that's the risk for mortality, treat the fluid balance. Again, hypotension is a risk for the patient. And 3, clearly, it's an infection and you need to kill the pathogen, and that's going to require antibiotics. And then you need to monitor to make sure that the patient's improving with whatever management you've instigated. So to take these in turn, confirming the diagnosis, essentially, that's a chest X-ray. You think the patient has some crackles over the right lung and they're presenting with a fever, then you need to know whether there's consolidation present. So do a chest X-ray, and it might show lobar consolidation, as is shown here in the right lower lobe in this chest X-ray. It's also very important to do a chest X-ray to look for complications, and we'll discuss some of those later in this talk, but we're talking largely about pleural effusion. And there may be related pathologies. So, for example, if you have a lung tumor which is blocking a bronchus, then you'll get pneumonia distal to that obstruction quite easily. So a chest X-ray might help identify patients who have coexistent pathology which is relevant, such as a lung cancer. And also, it will help confirm that there isn't another diagnosis present and that you've been fooled and this is not your pneumonia. For example, pulmonary edema, etc. Sometimes you might need to do more extensive radiological investigations, such as a CT thorax or a CT pulmonary angiogram, but that's unusual. And if you're really worried about heart disease, then you're going to need to do an ECG echocardiogram. Now, blood tests are quite useful in patients with pneumonia because there are certain abnormalities that may show up. For example, if somebody's got an acute infection, you might expect the white cell count to go high, to be raised as an inflammatory response. That's true. It happens a lot in pneumonia, but also a low white cell count is also characteristic of infection in these patients as well. The urea and electrolytes can show significant abnormalities, commonly a raised urea and a raised creatinine due to a degree of acute kidney injury. And often patients have a low sodium as well, a hyponatremia. Liver function tests often are abnormal in patients with pneumonia, a high ALT and a high alkaline phosphatase, and the albumin is one of those markers of acute infection. So, for example, somebody gets acute pneumococcal pneumonia, their albumin may drop from its normal range of about 40 down to 25 very quickly. So hypoalbuminemia is a marker of infection.
Additionally, hypoalbuminemia is associated with increased severity, longer hospital stay, admission to the ICU, mechanical ventilation, and increased 30-day mortality.
Possibly the most important blood test is the C-reactive protein. This is a marker of inflammation. So if you have pneumonia, it's infection, there should be a very significant inflammatory response. So the C-reactive protein, which is normally less than 5, goes up very rapidly in most patients with pneumonia. In fact, it's not uncommon for it to be above 100, 200, and even 500 or 600 in patients with acute pneumonia. The other blood tests we need to do are tests for oxygenation, which I'll discuss later, and there are some blood tests which are tests for potential infecting pathogens, which I'll also discuss later. So, what's the differential diagnosis of somebody presenting with what you might think is community-acquired pneumonia? Well, we actually mentioned already, acute bronchitis, influenza bronchitis are two of the main differential diagnoses. The important thing there is they do not normally have evidence consolidation. If you have evidence consolidation either clinically or on X-ray, then that means the patient has a pneumonia rather than just a simple acute tracheobronchitis. Then there are a range of common non-infective respiratory diseases which really need to be considered of anybody presenting with an acute respiratory problem. Pulmonary emboli, pulmonary edema, acute respiratory distress syndrome, not that common but very important, and lung cancer. Now, the top two, pulmonary emboli, pulmonary edema, they're common causes of acute respiratory problems. And they're non-infective, so that you should be able to distinguish in most patients pneumonia from those. But if you look at the data, many patients with pulmonary emboli are misdiagnosed as pneumonia initially. And the same for pulmonary edema. So that needs to be considered in differential diagnosis. Lung cancer, because of this ability to cause infection distal to where lung cancer may be obstructing the bronchus, needs to be thought about, especially in the patients who are over 50 who smoke. Just think there may be a lung cancer underlying this problem, or that the X-ray shadowing that you're seeing is not consolidation, but a large tumor instead. ARDS is the subject of another lecture. It presents with bilateral consolidation and marked hypoxia, and is actually a consequence of pneumonia frequently. It can also occur in situations where there is, without pneumonia, And that's a relatively common presentation of bilateral consolidation, which might be confused with pneumonia in some certain circumstances. In addition, there are a range of relatively unusual and rare lung conditions which cause inflammation and consolidation, or what looks like consolidation on an X-ray. And these, because they cause inflammation and systemic upset and have X-ray changes suggestive of consolidation, could easily be confused with pneumonia. Now, fortunately, they're very rare, but they do need to be considered in patients who are not improving. So these include diseases such as cryptogenic organizing pneumonia, a non-infective form of consolidation, pulmonary eosinophilia, and that's where you get eosinophil forming consolidation in the lungs, allergic bronchopulmonary aspergillosis, which is a subject of one of the airways talks, hypersensitivity pneumonitis, and vasculitis, which are discussed in the interstitial lung disease talks and the pulmonary vascular talks, respectively. So, for example, this is a patient, 40-year-old man. He's had 2 weeks of fever and breathlessness, and a C-reactive protein shows there's quite active inflammation with a CRP of 222. Now, not unreasonably, he's been treated with antibiotics because it's thought that he may have an infection, a pneumonia, but he's not getting better. And in fact, it turns out that he has a disease, and you can see this here, which is causing an eosinophilic infiltration, a consolidation in both lungs, and as outlined by these the circles there. And this disease is called pulmonary eosinophilia, and the treatment that's required in these circumstances is corticosteroids. And with that, he gets better. So this is an unusual disease, but it's an example of what could be confused as community-acquired pneumonia. But I just have to reiterate, these are rare diseases, and they're only rarely considered in patients who are not getting better with antibiotics. Management, how do we assess the severity? And this is largely done using a score called the CURB-65 score. And this takes the 5 factors of confusion, whether it's present or not, a urea, whether it's greater than 7 or not, a respiratory rate, whether it's greater than 30 or not, blood pressure, whether the diastolic blood pressure is less than 60 or not, and whether the patient is over 65 years age or not. And that gives you a 6-point score, 0, 1, 2, 3, 4, or 5. And with that score, that defines how severe, or defines the mortality, the chance of death occurring with that episode of pneumonia.
For example, if the score is 0, the 30-day risk of dying is less than 3%. That's a mild disease, and most of these patients can be treated as an outpatient. With the score of 1 or 2, which is moderately severe, most of these patients will need to be hospitalized on a general medical floor. A score of 3 or more signifies very severe disease, with a high 30-day mortality risk, and patients should be admitted to the ICU for close and aggressive management. The Pneumonia Severity Index, or PSI, is a validated clinical prediction model that is both more complex and accurate. It stratifies patients into 5 risk groups using 20 variables from 5 categories, including demographics, medical history, physical examination, laboratory results, and imaging. It should be noted that clinical judgment still plays a critical role in caring for these patients, but the PSI can be helpful to guide management.
As well as the CURB-65 score, there are other features that can be used, other clinical features that can be used to identify patients who may have more severe disease. So worrying features are those who are hypoxic despite having a high inspired oxygen concentration, patients who seem to have bilateral disease or disease that spreads during the hospital admission despite the antibiotics. If somebody has a blood culture which is positive for an infective organism, that instantly places them into a group that has a mortality of about 20%. The C-reactive protein, the blood marker for inflammation, if it's particularly high, above 250, that seems to suggest patients who have an increased mortality in some data that's been published. And then if you have a severe comorbidity, if you have underlying cardiac disease, underlying COPD, or renal impairment, then that is quite likely to decompensate because of the acute infection, and that will increase the risk of severe consequences of the infection. So just to go through a couple of examples, here's patient A, age 53, presents to casualty with feeling of cough and phlegm and fever for the past 3 days. He's not confused. Urea was actually slightly high, 9.8, but not terribly breathless. Blood pressure was normal. That gives a CURB-65 score of 1, just for the urea alone. The rest were normal. So that's a 3% mortality. They're not hypoxic. Chest x-ray confirmed pneumonia, but actually they could be treated at home with some oral antibiotics.
Patient B, on the other hand, is 67 years of age, so he gets a point for that. And he's confused, so he gets a point for that, because normally patients are not confused. He has a urea of 10, so he gets a point for that. He is breathless, and his respiratory rate is 30, so he gets a point for that.
He does not have hypotension, so he does not get a point for that.
His total points give him a CURB 65 score of 4, and that suggests a mortality of about 28% for this type of patient. In addition, his respiratory rate was above 30. The PaO2 was low, it was less than 8 despite the patient being on 60% oxygen, and there is bilateral consolidation. So this is a severe disease that is markedly hypoxic. The patient needs to go to intensive care and probably needs to be intubated. At least if there's not an easy, quick response to high-flow oxygen, the patient will need to be intubated and ventilated because of his marked hypoxia. In this situation, the patient actually survived, although given the severity of illness, it was touch and go.
The other issues that you can get with pneumonia are the complications. So we've mentioned severe hypoxia, we've mentioned septic shock, and I've also mentioned ARDS. And these are all physiological complications that occur with severe pneumonia. In addition, you have renal impairment. Again, I have discussed that already. But there are other complications. Patients in hospital are at risk of a deep vein thrombosis, so they might develop a deep vein thrombosis. Atrial fibrillation is a common complication of acute pneumonia, and that will settle as the patient gets better. Another important thing is acute cardiac ischemia, and that occurs in patients who are being stressed. And pneumonia is a great physiological stress for the body, and therefore, if somebody has underlying ischemic heart disease, then that could precipitate a myocardial infarction or angina or a decompensation if they've got cardiac ventricular impairment. So the important complications of pneumonia not to miss are infective ones, and this largely comes down to pleural effusions. Parapneumonic effusions, these are small effusions that occur in patients with pneumonia and are not infected, are present in about a third of patients, and these will resolve as the patient gets better. However, in a minority of patients, about 7%, 5 or 10%, that infusion will become infected and become a complex parapneumonic effusion, and eventually that moves on to forming an empyema. So this X-ray shows somebody presented with a left lower lobe pneumonia, but now you can see that the C-reactive protein was very high on the day of admission, about 330. 7 days later after treatment, it got better, but then a couple of days later they redeveloped a fever, and the CRP has jumped back up to over 140. And the chest X-ray here shows some left-sided shadowing, the pneumonia, but also you can see there's some pleural shadowing going up the left-hand side of the chest. And this reflects an infected pleural effusion. And you can see that on the chest X-ray, and that is that diagnosis would be empyema in these situations, a complication of community-acquired pneumonia. Other infected complications are actually pretty rare, but you can get lung abscesses, and these are more likely in alcoholics or those who've aspirated, and is actually more likely with certain bacteria, Staphylococcus aureus, Klebsiella, and anaerobes. You can also get spread of infection from the lung to other parts of the body. This is pretty rare, but occasionally you get peritonitis, and infective arthritis, endocarditis as a complication of pneumonia. What is actually quite common in somebody who's been in hospital and treated for pneumonia, and the infections initially got better, then has deteriorated with an increasing fever again, is that they may have a line-associated cellulitis. So initial antibiotics given in pneumonia will be intravenous, and where the intravenous cannula has been placed, there's actually a relatively high chance that they can develop a cellulitis during their hospital stay. An antibiotic therapy can cause Clostridia difficile diarrhea, a superinfection of the gut with Clostridia difficile, and that is actually quite a common complication of patients receiving antibiotics in hospital and can be quite dangerous. So, tuberculosis. What's the epidemiology of tuberculosis? Well, 30% of the population of the world are infected with tuberculosis. Fortunately, most of those patients have what we call as latent infection. That is, the bacteria is present in the body, but it's not causing active disease. Of those 30% of the population of the world, it's estimated about 10% will actually have reactivated disease from that latent disease over a lifetime. What that means is that the dormant bacteria start replicating and actually start to cause an infection. At any one time, there's about 10 million people across the world with active tuberculosis infection, and that causes deaths in about 10% of them. So we're talking 1 million deaths per year. And that makes tuberculosis the first or second commonest cause of bacterial infectious death across the globe. What's tuberculosis caused by? It's caused by the organism Mycobacterium tuberculosis. Now, this is quite an unusual bacteria. So unlike the bacteria that cause normal acute pneumonias, it's quite slow growing. It takes several weeks to culture it in the laboratory. It has a very unusual cell wall full of lipid, and there is no environmental source. You cannot catch tuberculosis from the environment. You catch it from somebody else who's already infected with the bacteria. There are a couple of subspecies of Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanus, and there's also the BCG. Now, that is a Mycobacterium bovis that has been cultured in the laboratory and is now not pathogenic, doesn't cause disease, or rarely causes disease, and we use that as the vaccine to try and prevent M. tuberculosis infection. As I've already mentioned, there are environmental mycobacteria which are related to M. tuberculosis, and these are called the non-tuberculous mycobacteria, and there's quite a large range of different species, and they can cause a similar disease to tuberculosis sometimes, but they are far outweighed by patients infected with M. tuberculosis. So the pathogenesis of M. tuberculosis, like influenza A, requires being infected by somebody with active disease. So if somebody has active lung disease with tuberculosis, they will cough, and in the cough there will be infected droplets carrying the bacteria that can be inhaled by somebody else. And once the bacteria is inhaled, it goes into the lung, and there it actually invades your normal mechanism for protecting the lungs against bacterial infection, which are the alveolar macrophages. It actively seeks out and invades these macrophages because it's able to prevent the normal macrophage killing mechanisms. So it diverts the normal phagolysosomal pathways, and that allows it to survive within the macrophage, and it can be latent in that macrophage for decades. In addition, the macrophages, because they move, will allow the bacterium to spread across the body. And this is one of the reasons why sites of immune function, such as the lymph nodes, often get infected with tuberculosis. And long-term persistence within the macrophages is what latent disease is. In addition, there's a certain inflammatory response to this infection, which causes a very distinctive histological appearance called granulomas. And that is one of the hallmarks of tuberculosis infection, is the presence of granulomas in the infected tissue. So, to talk about the disease, there's two main forms. There's pulmonary tuberculosis, which is TB affecting the lungs, and there's extrapulmonary tuberculosis, which is TB affecting outside the lungs. Just to describe the pathogenesis in a bit more detail, what happens is you're in contact with somebody with open pulmonary tuberculosis, and what we mean by open pulmonary tuberculosis is that if you look at the patient's sputum, you will see the bacteria present when you stain it with a special stain called acid fast bacilli stain. So their sputum AFB positive is the description that's used. The tuberculosis reaches the lungs, invades the macrophages, but in fact, quite a lot of the time, 50% of people, it will be killed and removed from the lungs and not cause any problems at all. In some people, it will actually start to cause primary disease or replicate enough to cause infection in the lung. And that's classically described as a Gone focus, where you have a mid-zone patch of abnormal shadowing representing the replicating bacteria and the inflammatory response to that infection at that point. In the middle, what we have is patients with latent disease. So the invasion of the macrophage does not lead on to active disease, but the bacteria becomes dormant and stays within the macrophage for very many periods of time, a very long period of time. And in fact, if you're infected as a child, it is quite likely you have latent infection present at the point when you die, even if that may be 70, 80 years later. So the majority of people will fall into the cleared infection or perhaps having latent infection. So what can happen with the small minority with the active infection is that can progress, and it can progress to affect other parts of the body. So as well as having pulmonary tuberculosis, it can spread to affect the lymph nodes, the pleura, affect the mind, the brain with the TB meningitis, and perhaps other parts of the body as well. With latent disease, over a long period of time, that may reactivate. And that occurs in about 10% of people with latent disease, as I've mentioned already. And that reactivation is a situation that occurs is more likely to occur when immune surveillance is weakened against the bacteria. So as you get older, your immune response becomes weaker. If you are malnourished, then your immune response also becomes weaker, and that may allow the bacteria to reactivate. And there are drugs that we can give people that may allow the reactivation as well. Corticosteroids, anti-tumor necrosis factor treatment, specifically, it makes you much more likely to reactivate latent tuberculosis. And infection of HIV is a very important reason why people may get reactivated disease and is associated with quite a high proportion of cases of tuberculosis across the globe. A slightly unusual and the reason why this occurs is not known, is that if you emigrate, you actually also increase the risk of reactivated disease. So in the United Kingdom, for example, we have quite a lot of people emigrating from countries with high risk of tuberculosis who have latent disease. And within 4 or 5 years of arriving, they frequently develop reactivated tuberculosis. So overall, if you look at the epidemiology of tuberculosis in the United Kingdom, the median age of diagnosis is in the mid-30s. There's a slight male preponderance, but essentially it's a disease that's split relatively equally between men and women. The chance of having infection is dictated by what happens as a child, whether you're likely to have developed latent infection or not. And that is dictated by the prevalence of tuberculosis where you live. And therefore, people who are brought up in countries with a high prevalence of people with open tuberculosis, and that's sub-Saharan Africa, the Indian subcontinent, and parts of the former USSR, then you are likely to have latent tuberculosis, much more likely to have latent tuberculosis, and therefore develop reactivation disease as you get older. The mid-risk countries are other Asian countries, the north parts of Africa, the Middle East, South and Central America. In addition, people who are at the margins of society are also quite likely to get exposed to tuberculosis. The homeless, alcoholics, drug addicts, people who have been imprisoned. So this defines the patients most likely to have tuberculosis, where they were born, and if they've been born in the West, whether they have the situation of being homeless or alcoholic or drug addiction. And that means the ethnic breakdown of people with tuberculosis in the United Kingdom is heavily biased towards people who were born abroad. And that's why 35% of people with tuberculosis in the United Kingdom are of South Asian origin. And another 18% are from sub-Saharan Africa, with Caucasians only making up 25% of the population. So just to go over the risk factors of disease in a bit more detail, recent emigration, as we discussed, for some reason makes latent tuberculosis very likely to reactivate. Vitamin D deficiency has the same effect because vitamin D is an immune modulator, and deficiency of that weakens your immune system, protecting you against tuberculosis. The same for HIV infection, which is present in 8% of cases of tuberculosis. And this problem of HIV allowing TB to reactivate or become a problem is actually before the patient has become heavily immunosuppressed. Smoking, diabetes, and the elderly, being elderly, are all examples where your immune system has been weakened to a degree and allows potentially the infection to take hold and cause a problem. We've already discussed homelessness, drug abuse, and alcoholism. And there's the other immunosuppression, steroids after transplantation, tumor necrosis factor treatment. All these will make you more likely to reactivate latent disease. So the clinical manifestations of tuberculosis are lung alone, pulmonary, which is nearly half of people, a combination of lung plus outside of the lung disease, which is only about 10% of people, and then there's just extrapulmonary disease that's not affecting the lungs, and that includes the mediastinal lymph nodes, because they're not actually part of the lung, they're in the mediastinum. and it also includes pleural tuberculosis because pleura, the infection is actually is of the pleura itself. Again, that's not the lung parenchyma. Now, an important distinction here is that infective disease are those patients with pulmonary disease, and all the extrapulmonary forms of tuberculosis are essentially not infective. You can see there's quite a big list of different sites that can be affected by extrapulmonary disease, and the frequency is given here as well. The commonest being nodes, lymph nodes, mediastinal lymph nodes being the commonest sites. But it could be pleural, you can have bone and spine disease, you can have miliary tuberculosis, which is a very specific form where the TB has been spread by the blood throughout the body, affecting mainly the lungs, the liver, and the bone marrow. Meningitis, which is a very serious form but relatively rare, fortunately, and then the various parts of the abdomen can be affected as well. So the classic symptoms of somebody presenting with pulmonary tuberculosis is very simple. They cough, and they may cough with blood present in the sputum, hemoptysis. And with that, they'll have systemic symptoms because it's an active infection. And these systemic symptoms are prolonged because the patient presents with several weeks, even several months worth of history. So over that time, the patient's feeling ill, they're not eating, and they have fevers and night sweats, and they'll be losing weight as well. And that's very important for identifying somebody who may have active tuberculosis, the presence of the systemic symptoms. Now, the other areas within the thoracic cavity that may be affected are the mediastinal nodes, as we've mentioned, but really that doesn't normally cause symptoms of the nodes themselves and is visible on the chest X-ray. And that sort of patient will present with the systemic symptoms, but no necessarily respiratory symptoms. And pleural disease, that causes an exudative pleural effusion, and that presents largely with breathlessness and the systemic symptoms that we've described already. Now, if you have extrapulmonary disease, how you present depends on the site of disease, clearly. So, cervical lymph node involvement is very common, and those patients will present with a lump palpable in the neck that they can feel or see themselves. And that lump tends to be smooth, it's firm, it's not particularly hot. If they have mediastinal or abdominal lymphadenopathy, then that will be identified by X-rays. Gastrointestinal disease will cause pain, bloating, and ascites. Pericardial diseases cause constrictive pericarditis and pericardial effusions. Meningitis presents with chronic headache, focal neurology, and eventually coma, and is a very serious problem with a high mortality. And even if you do survive it, you're likely to have a neurological defect as well. Miliary TB, I've mentioned, is where you have blood-borne spread across the body. And actually, that's very difficult to diagnose because the patient has very few in the way of localizing symptoms. They just have the systemic symptoms and weight loss. But the chest X-ray is often characteristic, showing very small nodules throughout both lungs. If you have bone and joint TB, that will present with a mass and pain of that bone or that joint that's been affected. And if you have nodal TB and bone and joint TB, then what can happen is that the infection can penetrate through the skin and cause what we call a discharging sinus. We have a hole going into the infected area that oozes out fluid, and tuberculous organisms can be seen in that fluid. So just to give you a couple of case histories to give a feel for what this disease, how this disease presents. This first patient is a man from India. He's had 3-month history of the systemic symptoms of weight loss and night sweats and feeling not very well. And with that, he's had a cough. And if you can see the chest X-ray, what you can see is bilateral apical disease here. And there's cavitation present. And this is a very classical presentation for somebody with pulmonary tuberculosis. Systemic symptoms, cough, and a chest X-ray showing upper lobe changes with cavitation. And given the man was born in India, this is almost certainly going to be tuberculosis because he's from a high-risk group with a very classical presentation of what pulmonary tuberculosis looks like. And his sputum should show acid-fast bacilli because this is a high bacillary load, high bacterial load disease. This is a different presentation. There's a Somalian has moved to London and now is presenting with 2 months history of back pain and again systemic symptoms of sweats, feeling not very well, a bit of weight loss. Now, the back pain is the localizing symptom for where the problem is. And you can see this on this MRI scan. There's an area of high density, high signal density occurring in the thoracic vertebra. And in fact, if you look closely, there's destruction of the edges of those vertebrae. And there's some soft tissue swelling around those bones. And you can also see that there's an angulation occurring there. And this is spinal TB, and the MRI appearances there are very classical for tuberculosis. So again, we have somebody from a high-risk area, sub-Saharan Africa, so therefore has been exposed to tuberculosis as a child, quite likely to have been. Recent emigration, which is a risk factor. Systemic symptoms, which are very indicative of active inflammatory or infective disease, tuberculosis being one of the common causes, and a characteristic radiology. So, just to reiterate that, to recognize tuberculosis, really you need two things: systemic symptoms plus a high-risk group. So somebody who's got weight loss, fatigue, fever, sweat, who has been born in a high-risk country, sub-Saharan Africa, Asia, or is homeless, intravenous drug abuser, alcoholic, has been in a prison, or is HIV positive. That combination, you must think about tuberculosis. And the localizing symptoms will help as well, because if somebody has classic localizing symptoms, that will also make the disease much more likely. A family history of exposure to tuberculosis is sort of helpful. If somebody says, yes, my aunt had TB when I was a child, then that means they're quite likely to have latent tuberculosis. But we don't often get that history. How do we confirm the diagnosis? Well, frequently, the diagnosis is clinical only. If you're in a developing world where you don't have access to the investigations that we have in the industrialized countries, then you may have to rely on clinical diagnosis. Confirmed diagnosis requires seeing or culturing the bacteria in a sample from the patient. And for lung disease, what we do is we send 3 morning sputums for culture and microscopy. For extrapulmonary disease, we may be able to get a sample. So, for example, genital urinary disease, the urine might be positive. Meningitis, the CSF might be positive. But we often have to do biopsies of the affected tissue as well, because that will give us a sample for culture and also for looking histologically for the characteristic granulomas that I mentioned earlier. So, microscopy, what we're looking for is acid-fast bacilli. There's a special stain used for mycobacteria, and if they're present, they will be positive for that stain and show up on microscopy. And that shows that there's a mycobacteria present in that sample. And sort of 95 times out of 100, that mycobacteria will be tuberculosis, although occasionally it is one of the non-tuberculous mycobacteria that I mentioned earlier in this talk. Culture is very important because it confirms that that mycobacterium present on us in microscopy is M. tuberculosis. And more importantly, it gives you the resistance profile, whether that bacteria is a sensitive M. tuberculosis or resistant to some of the drugs that we might use to treat it. The big problem with culture is that it's slow. It takes 3 to 4 weeks. So you're often left with a patient who has given a sample, no acid-fast bacilli have been seen in it, and you're waiting now for the culture to occur. And you need to make a decision about whether the patient requires treatment for TB because you're really sure that they may have TB. For example, in one of the examples I showed earlier, the Bengali man, he would be treated before we got the culture results back, even if he was AFB negative in his sputum, because the clinical presentation was so clearly going to be tuberculosis. But if it's not clear, then you're just left waiting. Patients with pulmonary tuberculosis, their sputum will be culture positive for the mycobacterium in 60 to 70% of cases at least. However, for extrapulmonary tuberculosis, the chance of culture being positive is not so high for some diseases. Nodal disease, lymph node disease, pleural tuberculosis, and TB meningitis, the yield from culture is much lower. Recently, there's a polymerase chain reaction which has been developed, a test which has been developed, which is useful for identifying tuberculosis much more rapidly than culture does. And that's actually positive even in patients who are not AFB positive. And that has improved our ability to rapidly recognize patients with tuberculosis. We also use biopsies to try and prove that tuberculosis is present. Now, this is particularly important for extrapulmonary disease. And what the biopsy will show is the presence of granulomas, which is that very specific histological appearance that reflects the immunological response to the presence of a mycobacterium tuberculosis. And in fact, with TB, there are very specific granulomas which have a central area of necrosis, and that's called caseating granulomas. And we use biopsies of the pleura, abdominal disease, the lymph nodes to confirm the patient may have extrapulmonary tuberculosis. Now, the main differential diagnosis when you have histology showing granulomas is of sarcoid. Now, in most clinical circumstances, TB and sarcoid are not easily confused. The main exception being the presence of mediastinal lymphadenopathy. The difference between sarcoid and tuberculosis is that the granulomas in sarcoid tend to be non-caseating, and clearly you won't grow the bacteria M. tuberculosis from patients with sarcoidosis. We also use immunological testing, and what we use that for is to identify patients who've previously been exposed or infected with tuberculosis, and this therefore identifies latent infection. And we have two different methods for testing for that. One is the Heath test or MAN2 test, where we inject a mixture of tuberculosis antigens into the skin. And in patients who've previously been exposed to tuberculosis, that will stimulate an immunological reaction and a painful lump will form there. The other test is a more recently developed blood test, where essentially we do a very similar thing, is that you incubate the patient's blood with a tuberculous antigen, and you see whether the white cells have a response to that. And those are called the interferon gamma release assays. Their main advantage is that they're not confounded by previous vaccination with BCG. So, for example, I have a reasonably strong MAN2 reaction because I was vaccinated with BCG as a child. And that means it's very difficult to use that skin test to identify patients who may have been exposed to tuberculosis if they've previously had BCG vaccination. However, the interferon gamma release assay will only be positive in patients with previous tuberculosis exposure and is not affected by the BCG. The treatment of tuberculosis is actually relatively straightforward. It requires antibiotics. However, it requires more than one antibiotic, and the standard therapy is 4 antibiotics. And it requires antibiotics for a long period of time. The minimum treatment period is 6 months. And if you have central nervous system disease or bone disease, it often goes on for at least 12 months. So we'll ask the patients to take 4 drugs for 2 months and then 2 drugs for 4 months at least. And the actual dose that we give the patient is dictated by their weight, the split being 50 kilograms. If they're below 50 kilograms, they get a lower dose. If they're above 50 kilograms, they get a higher dose. And the 4 drugs that we use are isoniazid, rifampicin. Those are the most effective drugs and the ones that are kept going for 6 months. And for the first 2 months, we give the patient pyrazinamide and ethambutol as well. Ethambutol can affect the eyes, and therefore we test the eyes before we start that drug. There are other things we may want to do. One is that actually with patients with brain involvement of tuberculosis or pericardial disease, we give them corticosteroids. And the reason why we do that is that tuberculosis, as it heals, is a very scarring infection. So you get a lot of fibrosis occurring where tuberculosis has been. And in the brain, that causes neurological deficits. And we know that if patients are given corticosteroids, then the chance of having long-term brain damage is reduced. And the same for pericardial disease. We worry about the development of constrictive pericarditis, and the chances of that are reduced by giving the patient oral corticosteroids as well as their TB therapy. A very, very important point is that all the cases of tuberculosis need to be notified. And what we mean by that is that they need to be brought to the attention of the authorities so that there can be a screening process of that patient's close contacts, usually the family, the people they live with, but if it's a school child, it will also be their school class as well. And what happens there is that if a patient with TB is identified, then who they live with will be tested to see whether they have active tuberculosis or latent tuberculosis as well. And by this method, we can identify the source by which a patient has been infected and whether they've actually infected somebody else as well. And this is very important for the control of the disease. And the testing that we use is this immunological response to infection, the Heath testing or the IGRA, and a chest X-ray to look for active disease. There are major problems with treating tuberculosis. The first we've already mentioned is that diagnosis can be slow if it's relying on culture where in fact it takes 6 weeks before you know somebody doesn't have tuberculosis in a sample that's been sent for culture, and the positive growth is only usually occurs within 3 or 4 weeks. The second is compliance. You're asking somebody to take quite a lot of drugs for 6 months, and they don't like doing that. And in fact, when patients feel better, they often think they don't need to take the medication. And they feel better within a few weeks of starting the medication. And within 2 weeks, they should be starting to feel considerably better than they have been feeling for weeks. And often, patients will say, well, actually, I'm feeling better now. I'll stop taking the tablets. The third is toxicity. The drugs that we use for tuberculosis, unfortunately, several of them are liver toxic, and they cause an inflammation of the liver with an increase in the liver enzyme results. And that can prevent those treatments being used. So we have to monitor the liver function test, and if they go too high, we have to stop the therapy and then restart the therapy, trying to identify which one of the drugs was responsible for causing the liver toxicity. And that's a complex process and delays treatment considerably. And the last is drug resistance. This is a problem if the patient is given single-agent therapy. So when we first developed therapies for tuberculosis in the 1950s, only one agent was available, and treatment with that led to patients developing resistant disease very quickly. And this is a problem. So this is why we give the patient 4 drugs to start with. It is to prevent resistance developing. And if resistance is present to one agent, if you give somebody 4 drugs, then that will prevent that resistance increasing to affect the other drugs as well. If somebody has resistant disease, you suddenly have a problem in that the treatment has to go on for at least 12 months. You may be using second-line drugs which are less effective, and they need very close monitoring to ensure that they're improving and that they're compliant with the drugs that are being used. If you have extensive resistant disease, those organisms that are resistant to rifampicin and isoniazid and several other drugs, then actually you can get a situation where the tuberculosis is not treatable, and there's a very high mortality in those patients. So what's the outcome? Well, if you have non-resistant tuberculosis, of 100 cases, you'd expect 90 to 95% of patients will be cured. So it's a very good outcome in most patients. And people should not really die of tuberculosis, and that only really happens if they have resistant disease or if the diagnosis is made late because the patient presents very late, or they have the more severe forms such as meningitis or miliary tuberculosis. There is a problem with TB, and that once you've had tuberculosis, it can cause a lot of lung damage. Now, this normally happens in people who've not been treated quickly or effectively. So this is not a common complication in the West, but is very common in people who are born abroad. And the extensive lung tuberculosis will leave extensive lung fibrosis, and that can have quite marked complications. You get poor lung function because there'll be extensive pleural thickening around the lung, and also there seems to be a degree of airways obstruction associated with extensive tuberculosis. You can get cavities formed by the tuberculosis, and those persist after the bug has been killed and the patient's healed of TB. And those cavities have been colonized by fungi to cause a mycetoma, and that might cause hemoptysis. And sometimes it causes major hemoptysis. And often in the areas of the lung which have been particularly affected by tuberculosis, you get bronchiectasis. And in my bronchiectasis clinic, about 5% of the patients had previous tuberculosis causing their disease, and they present with recurrent bacterial infections of the lung. So this is a chest X-ray of somebody who had tuberculosis when they were much younger, and you can see there's extensive scarring occurring on the left-hand side, and the left hemidiaphragm is raised halfway up the heart, and that reflects the fact that the left lung is much smaller than it should be. It's about half the volume of the right lung. And that's partly because of the scarring within the lung, but it's also because there's a layer of pleural thickening around the outside of the lung, gripping it, stopping it being able to expand. In addition, the right lung has quite a lot of scarring in the apices, and if you do a CT scan, you'll see that there's quite a marked areas of bronchiectasis and the occasional small cavity in that area as well. And this is a very classic situation that occurs with people who've had extensive pulmonary tuberculosis when they are younger and leads to chronic lung disease. And this patient has respiratory failure as a consequence of this, with type 2 respiratory failure, even when he's well. So moving on, pulmonary emboli. These are blood clots occluding the pulmonary arterial circulation. They're very common, 1 per 1,000 per year. And where they come from is, generally speaking, the distal deep leg veins. So somebody who has a deep vein thrombosis with a clot in one of their leg veins, then that clot can break off, move up the venous circulation, reach the right side of the heart, and then it is fired into the lung. Whereas the pulmonary arteries get smaller, it will eventually lodge and cause damage distal to where it's lodged. You can also get clots moving from the arm veins and the right atrium itself, but those are usually associated with indwelling lines. So the patient will have had a long-term catheter in for intravenous antibiotics if they have cystic fibrosis, for example, or perhaps they've got a pacing wire or something similar, which allows a clot to form in a place where normally they do not form. There are some rare causes of pulmonary emboli where the clot where the material that is embolized to the lung may not actually be clot, and these include amniotic fluid embolism that occur during delivery of a baby, fat embolism which occurs in patients who've had long bone fractures after a motorcycle accident, for example. Tumor embolism occasionally occurs where a tumor may actually cause lumps of cancer to fall off into the circulation and fly round to the lungs. And the same thing can happen with infected clots, which is most often occurs in patients who've had intravenous drug abuse, where they have right-side endocarditis and small bits of infected material can fall off the infected valve and go into the lung to cause clots and abscesses there. And then sickle cell disease is often associated with pulmonary emboli or disease that's similar to pulmonary emboli. Deep vein thrombosis and pulmonary emboli have the same risk factors because deep vein thrombi are the source for pulmonary emboli most of the time. And these risk factors can be divided into 3 different categories. One is increased coagulation of the blood, and the commonest cause of that would be pregnancy, the oral contraceptive pill, or other hormonal therapy, and malignancy, but also occurs when patients have congestive cardiac failure, if they have an increased platelet count due to problems with myeloproliferation disorders of their marrow, in patients with chronic inflammation, and also in smoking. Endothelial wall damage will make a clot more likely to occur, and this is most obvious in patients who've had pelvic surgery of some description, either gynecological or orthopedic surgery, in which case they have a very high risk of developing a DVT and then potentially a PE after that. And then if the blood flow is reduced because of immobility, surgery, pregnancy, etc., that will also make a clot more likely to form. And so from this, you can identify the patients who are most at risk of DVTs and therefore of PEs. And those are patients with malignancy, recent surgery, especially pelvic or orthopedic, those who are pregnant, those who have been immobile due to a long flight or a long car journey, etc. Emboli to the lungs will vary in their clinical presentation depending on the size of the embolus. And we can divide this into 3 main categories. In the acute presentation, this might be a medium-sized clot, and this will fly off into the pulmonary circulation, but not lodge at the beginning of the pulmonary artery, but deeper down in one of the median pulmonary arteries and cause infarction of tissue distal to that. And these patients present with a short history, largely of cough, breathlessness, hemoptysis. A large clot, large enough to block a pulmonary artery, will have a very sudden history. And the main problem these patients will present with is the cardiovascular disturbance from blocking the pulmonary artery. The whole of the body's circulation goes through the pulmonary arteries, and therefore if you make a significant obstruction to that, then that's going to have very marked effects on your blood pressure and your cardiovascular function. The last presentation is much more chronic, and those are multiple small clots. And these patients have a long history, which may be developing over weeks or months. And this is due to small emboli clogging off individually a small artery, but which in itself probably has little effect. But when you have multiple emboli clogging off multiple arteries, then that eventually will lead to breathlessness, problems with gas exchange, and the patient will present with breathlessness and potentially the consequence of pulmonary hypertension developing due to loss of the arterial circulation due to multiple small clots. So the acute presentation, any age, either sex equally, There's usually an obvious pre-existing risk factor. Recent surgery, have just flown back from Australia, is on the oral contraceptive pill, for example. The type of presentation, well, with the very large clots, that may be cardiac arrest. The patient may just drop dead, essentially. A sudden onset clot, not quite enough to stop the heart, will cause hypotension, cardiovascular shock, significant respiratory distress. The smaller clots, the medium-sized one, they will cause infarction of the lung, and that causes pleuritic inflammation and therefore pleurisy and pleuritic chest pain, hemoptysis, and breathlessness. And those are the classical presentations of somebody with acute PEs. With acute PE, the general signs will show that there has been some form of physiological disturbance. There'll be tachycardia, there may be a third heart sound, a raised JVP, showing that there's some sort of right heart strain. And of course, there might be evidence of the pre-existing DVT, although in many patients that is not clinically apparent. And then there are the respiratory symptoms and signs. They have a raised respiratory rate, there may be a pleural rub over the affected area where the infarction has occurred, and there might be signs of a small effusion, which is often associated with that pleural inflammation. The subject of this lecture is pleural disease, by which we mean pleural effusions, which can be transudates or exudates or infective in origin. In addition, we'll talk about pneumothorax, which is air in the pleural space, and pleural thickening. Mesothelioma, which is a primary cancer of the pleura, is actually discussed in the lung oncology lecture. There are a couple of important basic concepts about pleural disease. The first is that there are no divisions in the normal pleural space. And that means that when you have a pneumothorax with air in the pleural space, it will rise to the top, whereas if you have pleural fluid, then it will sink to the bottom, and pleural effusions are best detected at the base of the lungs. However, if you get an infection in the pleural space or a hemothorax, that is blood in the pleural space, or a surgeon has done some pleural surgery, then you get adhesions forming between the visceral and the parietal pleura. And that can cause loculations of the pleural space, divisions, and that will make the X-ray appearances of a pleural fluid or a pneumothorax quite different. The other basic concept is that the pleural space is under negative pressure, and this keeps the lungs inflated. And that means that when you get a pneumothorax, the lung will collapse. Pleural disease is actually readily detectable normally by clinical examination. The stethoscope will quite easily pick up a difference when somebody has a pneumothorax or a pleural effusion between the affected side and the normal side. And percussion note will readily pick up somebody with a large pleural effusion. The best test is actually a pleural ultrasound. And that is the most efficient way of assessing for pleural fluid and for divisions in the pleural space, and where there's any, and is also effective at identifying whether there's any masses or abnormality of the pleural surface itself. So pleural effusions, fluid in the pleural space. This is an X-ray on the right-hand side of somebody with a left pleural effusion. That should be readily detectable clinically, and you can see it quite easily on the chest X-ray. These are very common, and they occur in multiple different specialties because of the causes of a very large range will be seen by multiple different medical specialties. The presentation is either as an asymptomatic finding on a chest X-ray, or as the effusion gets bigger, the patient becomes more and more breathless. So that causes progressive dyspnea over days or weeks. Sometimes with the more inflammatory types of pleural fluid, those which are caused by infection or perhaps a pulmonary embolus, then pleuritic chest pain is actually a very prominent symptom. And pleuritic chest pain is very specific and very easily characterized. It's a pain that occurs on inspiration, and it's localized to where the inflammation is occurring, normally on one side of the chest. And you may hear a pleural rub over that area. So when you examine somebody with pleural fluid, what you'll find is that the trachea for large effusions may be deviated away from the affected side. The expansion of the lung with the pleural fluid around it will be reduced. And when you percuss, it will be very dull over the pleural fluid because the air has been replaced by liquid. And that's described as stony dull because it's very dull indeed. You won't be able to hear any breath sounds, and vocal resonance will also be reduced over the area of the effusion. Sometimes at the top of the effusion, you may hear an area, a patch of bronchial breathing, and of course you may hear a pleural rub if there's inflammation of the pleura, but that will be heard where the visceral and the parietal pleura are actually allowed to oppose each other, and therefore won't be heard over the areas of large effusions, but areas where the effusion is much smaller. There may be also signs of what the cause of pleural effusion is. So, for example, there may be palpable lymph nodes if somebody's got a cancer, or an enlarged liver if somebody has a cancer with liver metastases. There might be signs of chronic liver disease, heart failure, or rheumatoid arthritis, all of which are associated with pleural effusions in some patients. The big question with pleural fluid is whether the patient has a transudate or an exudate. Now, the difference is that in a transudate, the pleura is normal, and what you're getting is excessive formation of pleural fluid by a passive transfer across from the blood. So this occurs in increased venous pressure, such as heart failure, or a low oncotic pressure of the blood, such as decreased blood protein content. These may be bilateral, but can be unilateral, and they can be associated with peripheral edema because the same mechanisms that cause pleural fluid in these patients will also be caused peripheral edema. Exudates, in contrast, the pleura is the abnormality. The problem is that the pleura is abnormal and driving fluid formation, and that occurs with tumor of the pleura, inflammation of the pleura, or infection. And these tend to be unilateral and won't have associated peripheral edema because this is a specific pleural abnormality. So what are the causes of pleural effusions? Well, with transudates, you can have an increased venous pressure, and that might be due to cardiac failure, mainly right-sided cardiac failure, but also left-sided cardiac failure. Could be fluid overload. Somebody who's got renal failure and they have an excess amount of fluid in the system, then you may get pleural fluid forming. And pericardial disease also causes pleural effusions and is often forgotten as a cause of these. The protein content of the blood is required for retaining fluid within the blood, and with a low albumin content, you end up with the fluid seeping out into the pleural space, into ascites, and into the peripheral edema as well. So patients with very low protein content of the blood will present with pleural effusions. These include liver cirrhosis, nephrotic syndrome, and very rarely protein-losing gut enteropathies or malabsorption. But the commonest cause there would probably be the renal and the liver problems. Exudates, in contrast, are due to abnormalities of the pleura, as I mentioned before. So these occur in tumors, and usually there's a secondary pleural metastasis, either from a lung cancer, from a breast cancer, or from a GI tract malignancy. So those are the common causes, but in fact multiple different types of cancers can spread to the pleura to cause pleural effusions. And the presence of a pleural effusion in somebody with a known malignancy is very suggestive that they're going to have metastatic disease affecting the pleura. Then again, there are primary pleural cancers as well. Actually, these are very rare in general, apart from mesothelioma, which is a primary cancer of the pleura that is associated with asbestos exposure that I've discussed in the lung oncology lecture. There are other causes of exudate pleural effusions. These are basically involve pleural inflammation. Probably the commonest cause might be a pulmonary embolus, where you often get small effusions formed with that. But then there are connective tissue diseases. Rheumatoid arthritis, for example, will often have patients with pleural effusions, and systemic lupus erythematosus is another cause of inflammatory pleural effusions. Benign asbestos effusions occur in people who've been exposed to asbestos, where the asbestos has inflamed the pleura and caused an exudative pleural effusion, but hasn't gone on to cause a mesothelioma. Occasionally, drugs can cause pleural effusions, the classic example being pratilol. And then actually, many exudate pleural effusions, we cannot identify the cause and are characterized as idiopathic. The last major category of exudative pleural effusions are those due to infection. This is an incredibly important category. And these occur in three main circumstances. One is a parapneumonic effusion, which is an effusion associated with pneumonia. The second is the empyema, which is a pleural infection without associated pneumonia. And the third, very important, is tuberculosis. There are a whole range of very rare causes of pleural effusions, and these include chylothorax, where you have chyle forming in the pleural space, ovarian tumors called Meags syndrome, pancreatitis can cause inflammation of the pleura, and of course trauma itself can cause leaking of blood into the pleura, and that's called a hemothorax. But those are all, in general, relatively rare or obvious diagnoses. So how do you investigate somebody with a pleural effusion? Well, first off, you need to confirm there's a pleural effusion by doing a chest x-ray, and a pleural ultrasound will be also very helpful indeed. This is an ultrasound picture showing that clearly a very black area, which is the fluid, with the lung separated from the chest wall by that black area. If somebody has bilateral pleural effusions, then they're likely to be Transudates just because they're bilateral. So somebody with bilateral effusions and an obvious cause for a Transudate, such as known heart failure or low albumin due to nephrotic syndrome, then actually you don't need to do any further tests. The answer as to why the patient has pleural effusions is there. It's due to the cause of the Transudates. The subject of this lecture are interstitial lung diseases. These are non-infective, non-malignant infiltrations of the lung parenchyma. That is, they are diseases where the alveoli and the interstitium, the gap between the alveoli and the pulmonary capillaries and the rest of the lung, is infiltrated by non-infective and non-malignant cellular and extracellular components. There are a range of diseases which are in this category, the most important of which is lung fibrosis and sarcoidosis. In addition, there are diseases which are responses to inhaled substances and antigens, such as hypersensitivity pneumonitis and pneumoconiosis, and a large range of unusual and very rare interstitial and infiltrative lung diseases, which are normally included in the ILD category. In general, ILDs, interstitial lung diseases, cause a restrictive lung function pattern. That is, they reduce the FEV1 and the FVC, but as you can see on this diagram on the right-hand side here, that the ratio between the FEV1 and FVC is often increased, and in fact, total lung capacity is reduced as well. In general, CT scans are also essential for an accurate assessment of these types of diseases. Pulmonary fibrosis is often a progressive disease and is actually very difficult to treat. Categorizing ILDs is not straightforward. This is one way of categorizing ILDs and is a useful way of thinking about them in general. So, for example, here we have 5 categories. On the right-hand side, you have pulmonary fibrosis, and that has several different causes. It could be idiopathic, which is the commonest cause and means that we don't know what's causing it, or it can be associated with connective tissue disease, such as rheumatoid arthritis or dermatomyositis. In addition, there are a range of other situations where pulmonary fibrosis develops, such as radiotherapy, drug-associated, various drugs after adult respiratory distress syndrome. The other categories are hypersensitive pneumonitis, and these are the commonest causes of that are farmer's lung and bird fancy's lungs, and these are immune reactions to inhaled antigens and is a form of allergy. Sarcoidosis, the cause of which is unknown, is a disease in which you get infiltration of the lungs with granulomas, and that can present in acute disease or a chronic disease, and it can have lung involvement, pulmonary sarcoidosis, or involvement of other organs, extrapulmonary sarcoidosis. Then there are pneumoconiosis, which is a non-allergic response to inhaled substances such as coal dust, asbestosis, which causes an interstitial lung disease of various different patterns depending on what the substance is that you're inhaling. And then the last category here are the very rare diseases, which I'm not going to discuss in any detail today, which are often called interstitial lung diseases, but have their own distinct patterns and types of infiltrations. Now, very important components of this diagram are the arrows showing that patients with severe hypersensitive pneumonitis, severe sarcoidosis, severe pneumoconiosis, and some of the other rare interstitial lung diseases with aggressive severe disease end up with what looks like pulmonary fibrosis at the end. So, for example, if you have end-stage sarcoidosis, it actually looks clinically and radiologically very similar to end-stage pulmonary fibrosis. And as a consequence, sarcoid, hypersensitive pneumonitis, and various pneumoconiosis are thought of as causes of pulmonary fibrosis. Another important point from this slide is that there are old names for some of these diseases. For example, idiopathic pulmonary fibrosis used to be called cryptogenic fibrosing alveolitis, and hypersensitive pneumonitis used to be called extrinsic allergic alveolitis. These terms are interchangeable now. Pulmonary fibrosis is the commonest cause of interstitial lung disease and the most important clinically. As mentioned already, it's due to an infiltration of the interstitium and alveoli with the inflammatory material and increased extracellular matrix and collagen and fibroblasts. This is normally in a bibasal distribution, usually subpleural, usually relatively symmetrical, and importantly, pulmonary fibrosis of the idiopathic type is generally a progressive disease. This infiltration of the alveoli interstitium with extra material makes oxygen diffusion from the alveolus into the pulmonary capillary much slower. So uptake of oxygen, as measured by a transfer factor, will be reduced in pulmonary fibrosis. There are multiple underlying causes of pulmonary fibrosis, but idiopathic is by far the commonest. And there really is no idea exactly why these patients develop pulmonary fibrosis. It's commoner in patients who smoke and in patients who have had occupations where there's been dust exposure, suggesting there is some form of environmental insult that underlies why these patients might develop disease. In the United Kingdom, the incidence of idiopathic pulmonary fibrosis is 5 people per 100,000. This table describes the differences between the different causes of pulmonary fibrosis. At the top, you have idiopathic disease, which, as we already mentioned, is a bibasal, symmetrical, progressive disease. It tends to affect men. The median age of onset is 70 years. There's a very similar disease, but that's associated with connective tissue diseases such as rheumatoid arthritis, systemic sclerosis, and dermatomyositis. And this is a more even distribution between men and women and tends to affect younger patients, but again is a bibasal, symmetrical disease and can be progressive, although overall the prognosis of connective tissue associated pulmonary fibrosis is much better than idiopathic pulmonary fibrosis. Then you may get diseases such as end stage of sarcoidosis or hypersensitive pneumonitis, where the disease is not bibasal distribution but tends to be upper lobe disease. As I've already mentioned, both sarcoid and hypersensitive pneumonitis may cause pulmonary fibrosis, but this tends to be an upper lobe distribution rather than basal. Then there are some causes of pulmonary fibrosis which often start with an acute onset, such as drug toxicity, radiotherapy, and after an episode of adult respiratory distress syndrome. So how does pulmonary fibrosis present? Well, usually it presents with exertional dyspnea. The patient will say, I've been getting breathless and more breathless over the past few weeks or few months. Sometimes the patient may have a cough as well, which is usually dry but can be productive of clear phlegm. When you talk to the patient and discuss their background history and their social circumstances, you may identify a potential cause for pulmonary fibrosis, such as a history of rheumatoid arthritis, somebody who may be a farmer, could have farmer's lung, one of the forms of hypersensitive pneumonitis, or they could have worked with asbestos in the past and therefore have pulmonary fibrosis due to asbestosis. In addition, they could have had radiotherapy or chemotherapy, and that might be identifiable when you take their drug history and their past medical history. And other questions you may want to ask, and this always is a little unusual when you ask the patient, is whether they have any pets such as birds or any specific hobbies, because hypersensitive pneumonitis tends to be dictated by exposure during to pets or hobbies or specific occupations. The subject of this talk are lung cancers and lung tumours. Specifically, lung cancer itself, which is a malignant cancer arising from respiratory tract epithelium, but also lung metastases, that is, secondary cancers spread from elsewhere in the body to reach the lung, mesotheliomas, which is a primary malignant cancer of the mesothelium, and particularly associated with asbestos exposure, and a little bit about rarer lung tumours, which are small, benign or semi-malignant tumours, which are unusual, but are sometimes identified by radiology. So lung cancer. It's difficult to emphasize enough how important lung cancer is. It is the commonest fatal cancer. It's responsible for a total of 13% of all cancers. If you develop a lung cancer, there's a 90% chance that that cancer will kill you. It's relatively rare if you're under 50. But as you get over 50, the incidence of lung cancer increases and increases and increases, with a peak incidence occurring around 75 to 79 years of age, where 1 man in every 200 will develop cancer each year, and approaching 1 per woman in every 200 will develop the cancer each year. If you look at the UK, the lifetime risk for developing lung cancer for men is 1 in 14, and for women is 1 in 19. And for both men and women, it is the commonest fatal lung cancer, and in fact kills more people than the next 3 commonest cancers put together. There are 2 main histological characteristic types of lung cancer. The first is called non-small lung cancer, and that accounts for 80% of the disease. And this is further subdivided into 3 categories. One, squamous cell cancers. These tend to come from the larger airways in the center of the lungs and therefore present with hemoptysis and blockage of the airway. Adenocarcinomas, which in contrast to squamous cells tend to be peripheral tumors and arise from mucosal glands in the smaller airways distally. And large cell cancers, which are the smaller proportion, only 10% of these cases, which again is peripheral. And the histology of the lung cancers is very varied. The large cell lung cancers is varied. The other type of lung cancer is small cell lung cancer. This accounts for 20% of all cases. They, like squamous cell cancers, tend to be central tumors arising in the peribronchial epithelium, and they grow rapidly, and they metastasize early. They are sensitive to chemotherapy, but because they grow so rapidly and because even at presentation, most patients will have metastases somewhere, even if they're not detectable by radiology, surgery is not usually curative and not offered. And this is why there's such an important distinction between small cell lung cancer and non-small cell lung cancer. Because non-small cell lung cancer, your main aim is to identify patients who can be cured by surgical resection. Whereas in small cell lung cancer, that option is not normally available and they all get chemotherapy instead. So what are the classic presentations? Okay, so if you have somebody who is got lung cancer in a central place along one of the major bronchi, then they may present with cough. And if that tumor is eroding into the bronchus, they may bleed a little bit into the bronchus and have hemoptysis as well. Occasionally, that hemoptysis is fatal in that the tumor erodes into an artery that bleeds so fast that the patient will die with massive hemoptysis. However, if you've got a mass which is in the periphery of the lung, not near a main bronchus, then actually it can remain pretty asymptomatic for a very long period of time. And these tumors tend to be picked up by X-ray surveillance rather than by presenting with symptoms. The other presentation for a tumor which is affecting a bronchus is that it can block that bronchus and cause what we call lobar collapse. So that could be the right lower lobe as shown in this picture, could be the right upper lobe, could be the entire lung. This patient will present with an X-ray showing lung collapse and breathlessness that has developed over a period of a few weeks. When the lung hasn't quite collapsed but there's significant obstruction to the bronchus, then the patient on examination may have a wheeze over that area, which is a monophonic wheeze. It has one note, which is quite different to the wheeze you get in asthma, which is polyphonic with multiple notes. And the reason why it's a monophonic wheeze is that there's only one area of obstruction, so there's only one note of deturbent flow that occurs in that area. And of course, partial obstruction of an airways makes the body's ability to clear that airway, the distal lung of infection or bacteria that get into that area, much weaker, and therefore patients can present with pneumonia. So a smoker presenting with pneumonia, we have to be aware that that might be evidence of central obstruction due to a tumor that's otherwise unknown. As I've mentioned, an important range of symptoms for patients presenting with lung cancer are systemic symptoms. That is weight loss, loss of appetite, general malaise and fatigue. And if you have those symptoms, then you must consider cancer as a potential diagnosis. And the patients themselves may look cachectic because of the weight loss. They look particularly thin. Clubbing is also a very common sign in lung cancer and is a significantly present in many patients with squamous cell cancer. So just to take these potential presentations and give you three potential examples of this. This is a patient who has been coughing. They've coughed up blood. Because of that, somebody's done a bronchoscopy, and when they look down the bronchoscopy, what they can see is a tumor blocking the upper lobe bronchus. And the chest X-ray shows collapse of that upper lobe. So that's a central tumor which is causing partial collapse of the lung and hemoptysis. This next patient presents with pain in the arm, and the reason why they've got pain in the arm is that they have an apical tumor which is eroding into the brachial plexus, which is a so-called Pancoast tumor. So that's quite a different presentation, although it's still an upper lobe tumor on the right-hand side. And this third presentation, another upper lobe tumor on the right-hand side, actually, you can just about see there's a very small shadow visible underneath the ribs there. And this is an asymptomatic cancer. It's far too small to be actually causing symptoms in that peripheral position. But it was picked up on a chest X-ray that was done for other reasons. And this is a very common presentation for lung cancers, which is an asymptomatic abnormality identified on an X-ray done for other reasons.